Good day, students. Welcome to R.A.T.S, Racing Against Time for Students in Pathology. We shall start with the case history. A 65-year-old male with cachexia was bedridden for a few months. He developed congestion of the chest and pain on the right side of the chest. Follow me, right side of the chest. After supportive treatment, he was revived. However, he developed severe chest pain and collapsed. What is your provisional diagnosis? What was the reason for the 2 episodes of illness? Embolism. This is the topic we are going to deal with today. The importance of it is given in the enclosure. Please follow my class carefully. In this class, we shall be dealing the subject under the following headings. Always I used to say that think of the subheadings. The subheadings will lead you to the answer. Definition initially. And always definitions are definitions, no own words. An embolus is defined as a solid, liquid, or a gaseous mass that causes obstruction in the vascular tree at a distant site from its origin. An embolus is defined as a solid, liquid, or gaseous mass that causes obstruction in a vascular tree distant from its site of origin. This is the one. Usually the students answer thromboembolism, etc. or a thrombus. But we all know that there are other types which we shall be seeing. And this can lead to death of the organ, dysfunction, or infarction. Thromboembolism forms about 90 to 95% or even more of the incidents. Others will be much less than 10%. What are they? We shall start with pulmonary embolism. This commonly occurs in hospitalized patients who have been bedridden, and 0.2 to 0.4% of the hospitalized bedridden patients can develop pulmonary embolism. It is nowadays reduced because of the precautions being taken and physiotherapy. The site of origin is commonly the popliteal vein or the deep leg veins, and the site of deposit is the pulmonary artery at the bifurcation or in the lungs. So these things we shall be remembering. Look at this particular diagram. You find that there are veins and there are deep veins over here. And there is also a valve that is guarding against the backflow of blood. Now what will happen is whenever there is a clot within, a thrombus or whatever it is, it tends to get detached and it flows, leading to an obstruction. This is very common in patients who are bedridden because with no muscular action and stasis, there is a greater chance of thrombosis to develop. This is what we had explained earlier. And these are the veins that are there. Mostly it is in and around the popliteal veins or the deep femoral vein. Sometimes the leg veins are also the cause or the source of the embolism. So they all drain into the inferior vena cava, and the inferior vena cava goes to the right side of the heart. From the right side, you find that the thrombus will go into the right ventricle and it goes into the pulmonary artery. The pulmonary artery is a very large artery, it bifurcates and it goes to both the lungs. The pulmonary embolism itself, we shall be seeing what the type is, the size, the number, and what impact it can make and what is the fate. So you find that if it is going to be a very large thrombus, it will be staying at the bifurcation of the pulmonary artery. We call it a saddle embolus, we shall see it. And if it is of moderate size, it will get lodged somewhere in the middle. And if it is of a smaller size, it will go to the distal end of the arterial tree. So this is an example of a saddle thrombus. So this is the pulmonary artery. It has been bifurcated. You are finding the vessel here, the lumen on both sides, the right and the left. And there is a huge clot. It is actually a T-shaped or a Y-shaped clot that is astride the pulmonary artery at the site of bifurcation. And the patient immediately dies. It is called an agonal thrombus or a saddle embolus. So this is a diagrammatic one. This picture I think will be more congenial for us to understand. So it gets lodged at the site of bifurcation of the pulmonary artery. And at postmortem, you find that a clot like this can be removed from the site of bifurcation. And this is a saddle embolus. We had seen what a saddle embolus is. And now we'll go to the next term, a paradoxical embolism. And thanks to this author and his source, a beautiful set of diagrams which I would definitely feel all students will benefit from. So this is the inferior vena cava, the superior vena cava. They are all draining into the right atrium and the right ventricle, going into the pulmonary artery and into the lungs. So when there is any particulate matter, it goes to the pulmonary artery, it goes to the lungs. At the same time, I find that the left side of the heart is free of any such intrudents. Now in this particular picture, when compared to A, I find that there are particulate matters on the left side of the heart also entering the aorta. That is because the patient will be having what is called as a septal defect. It can be either an atrial septal defect or a ventricular septal defect, through which you find that an embolus that originates on the right side goes into the left side and becomes a systemic emboli. Since it originates from one side but goes to the other, it is called a paradoxical embolism. Paradoxical means true but opposite. Now, what are the sequences of this venous emboli? We shall see first. So, this is a vein over here, and whenever there is a stasis, I told you that there will be the valves in the vein which prevent the backflow. But these again will cause some kind of stasis. Therefore, there is a weak thrombus that is being formed. From this, there will be fragmentation and emboli will be released periodically. And these go. Look at see what is happening. They go into the inferior vena cava and then into the right side of the heart. In this also, I would like you people to kindly follow it. So this is the pulmonary artery over here. And in the pulmonary artery, there can be a large embolus, which will be affecting, say, a large branch. Or it can be multiple smaller emboli, which can go up to the periphery. Now, if the patient were to have a saddle embolus, as was explained earlier, he will die immediately. But if the embolus is quite large, pulmonary arterial saturation is double or dual. So you find that the patient gets oxygen from elsewhere. So there will not be infarction that easily. On the contrary, if the small embolus goes and obstructs a distal vessel, a definite infarction will develop. So when they ask you in the exam which is more dangerous, a smaller and a distal embolus is definitely more dangerous. And this is one organ, lung, where there is a double circulation and hence infarction is delayed. We had seen it in the earlier class. Arterial and venous thromboemboli. You find in the artery there can be an atheromatous plaque. We shall be seeing what it is later on. And from this, there can be a break in the endothelium, a clot can be formed, and there will be a detachment of the material with fibrin. This is called a thromboembolus. At the same time, you find this can happen on the venous side also, as explained earlier. This is a valve leaflet. There is a stasis after that, from which there can be fragmentation. Here, a lower force is required, whereas here, more active force is required. The arterial emboli can affect organs such as the brain, most common, heart, intestine, kidney, and the legs. But the brain and the heart will be the most commonly affected organs. What are the fundamental differences between the arterial and venous thromboemboli? Arterial, it is otherwise called as systemic. So it arises from the heart. There can be mural thrombi. Mural thrombi, it is a thrombus that occurs in large capacious chambers, such as the ventricle or an aneurysm of the aorta. So that is called a mural thrombus. It can fragment and you can get an arterial thromboembolus out of it. There can be vegetations, as in the case of infective endocarditis. Sometimes there can be systemic blood vessels which can be affected, as in atherosclerosis or in aneurysms of the aorta. So this will be the arterial. Just have an idea of it. The venous, on the contrary, it occurs in deep veins or in the pelvic veins or in cavernous sinus. They all end up in the lung, and ultimately they will be affecting the right side of the heart and the pulmonary artery. The infarct is restricted to the lung. This has been explained earlier. You should have three conditions in mind. One is a saddle embolus, two is a large embolus, and three is a smaller distal embolus. The systemic, on the contrary, you find that there is a thrombus that is being formed, it is getting detached, and finally it is affecting a smaller artery. You find a middle cerebral artery is being affected, and there is a broken of the internal carotid artery more proximally. So this will be causing an infarction, a triangular area of infarction at the watershed area. This is a beautiful picture I would like you people to remember, courtesy WebPath. Clear. So you find that there is an embolus that is being formed, it is detached, and it is going up to the bifurcation of the pulmonary artery. When it goes there, it gets caught, and this is called an agonal thrombus or a large thrombus that is outside the bifurcation of the pulmonary arteries. So such a massive one, there won't be time for development of any infarction. The patient will die immediately. It is called a saddle embolus otherwise. And this is the earlier picture of an arterial obstruction, as I had mentioned, in the carotid artery and infarction in the brain. The next type of embolism will be the fat embolism, otherwise called as marrow embolism. This can occur in fracture of the long bones. As we all know, the bones contain 50 to 60% of fat according to the age. And whenever there is a fracture of the long bones, the fat is released, leading to obstruction. Also, when there is any crush injury of the soft tissues, you find the fat can be released. Initially, it is in the form of small fat globules, but they can coalesce. Coalesce means joining together to form larger masses, which will cause occlusion. They can also combine with the elements of blood to form a thrombus. The common organs which are affected are the lungs, brain, and the kidneys. In the brain, all the small red areas are all areas of hemorrhage which are due to the fat embolism. Normally, the manifestations occur after a few days, but in some cases, there will be a severe casualty. Fat embolism, again, look at this one, it is a lung here. I'm able to see the well aerated tissue, but then there is a major blood vessel over here and it is showing multiple vacuolation. That is because of fat. I told you earlier the fat will be dissolved whenever you process the tissue in alcohol. So they appear empty. When we do a special stain otherwise with frozen section, they can be demonstrated. So you should mention what are all the various fat stains. Sudan 3, Sudan 4, Sudan black, Nile blue sulfate, etc. And there is a color which can be demonstrated by means of frozen section. Fat embolism. Air embolism is something different. You need more than 100 ml of air. Normally, when you give a patient an injection, you are supposed to empty all the air and then inject only the medicine. But supposing there is about 0.5 ml, nothing will happen. More than 100 ml is physically needed for an obstruction. The sources of the air embolism can be IV fluid airway. I shall be showing you a picture. Decompression sickness, caissons disease, air cabins which are not pressurized, as well as underwater workers. These are all the various sources, and the people who shall be suffering from it. Scuba diving. Caissons disease or a decompression sickness is a question for you people. You find that whenever there is a deep sea diving, you find that there is a tremendous amount of atmospheric pressure over here, and therefore all the gases such as nitrogen, oxygen, etc., they are all under pressure and they are emptied into your blood. At the same time, you find that when the patient, so long as he remains here, which is called the diving time, etc., it is fine. But when he tries to come up rapidly, there is a sudden decompression. Because of this, the air bubbles start coming out of the thing, and therefore they will be getting precipitated, particularly the nitrogen. It causes large bubbles and it will lead to obstruction of the vasculature, and that is called as air embolism. Normally, you find that the gas will be soluble under pressure, and this is called as Henry's law. Another example is the pressurized cabin. The pressurized cabin is this. You find that in the airplanes, so it is normally adjusted to the pressure at sea level. So therefore, when the flight is at high levels, you do not find any kind of a discomfort because the air cabin is adjusted to the pressure at sea level. At the same time, if the air cabin is not pressurized, the patient can develop what is called as air collection in the lung, which is called as emphysema, in the pleura, which is called as a pneumothorax, or sometimes it can enter the cerebral blood vessels, leading to cerebral embolism. Again, so this is a summary of it. I would like you people to kindly by heart this sequence of events. So there is pressurization. You find that the gases that are being inhaled, nitrogen, oxygen, etc., they are all dissolved in the blood. But when there is a decompression, the bubbles of nitrogen come out first and they cause a tissue ischemia. So there are three stages. There is a compression, there is a isopression, no change, and then there is a decompression. These are the three stages over here. And because of the tissue ischemia, two things occur. One is called the bends, the other is called the chokes. Bends, the patient will be bending up in pain. It affects the bones because of infarction and the muscles. Chokes, on the contrary, it affects the lungs and patient will be having a suffocating sensation. The lung becomes foamy, there can be a pneumothorax. And finally, there will be multiple areas of ischemia. Please memorize this, and I would like you people to explain the sequence of events in this. Whereas the caissons disease is slightly different. It is almost the same, but it is for people who are working for a long time underwater. So you find that the dissolution of the gas is equal to the partial pressure over here. Therefore, you find that the air will be under pressure and it gets into the blood. At the same time, when there is going to be a rapid decompression, there can be an air embolism. This is yet another example, and this is an IV fluid line. I hope you people are able to identify this particular diagram and credit to this particular person. A beautiful diagram that he has known, and this is just to diagrammatically represent the amount of air that is being released. Earlier, we used to have two kinds of IV fluid lines. This is called a plastic bag. Therefore, no external pressure is required. Atmospheric pressure is sufficient. And this will compress the bag and the fluid will go into the blood. Whereas in this, the bottle cannot be compressed and therefore you need externally what is called an airway. We used to just inject another needle. And through the needle, the air will be going inside, displacing the fluid which goes into the blood. But what will happen is sometimes if you forget to replace this needle or remove the empty bottle, the air will continue to go inside because it is under tremendous pressure. And that leads to what is called an air embolism. And incidentally, just to show what kind of an artist this particular person is, beautiful schematic diagrams have been, pictures have been drawn by this. And due credit to her. Another type of embolism will be the amniotic fluid embolism. During delivery, always I would like you people to just remember the fetus and the placenta, nothing more. And there are two types of circulations called maternal circulation and fetal circulation. Now what will happen is this is the placenta over here and this is the uterus of the mother and this is the fetus over here, and what will happen is it is attached. Sometimes you find that there will be a shearing force by which the placenta is getting separated. When the child is delivered, fetus is delivered, the placenta also comes along with it. But because of the shearing force, there can be a rupture of the veins at the placental site. Once there is rupture of veins, you find that it is a site of entry. Here, air or thrombus do not enter, but all the contents of the amniotic fluid. Amniotic fluid will be entering, and that leads to embolism. Let us see what kind of embolism it is. It is a very rare disease, but it is fatal if occurs. It will be fatal to the mother. There is a rupture of the membranes. Ruptured veins are there. The fetal contents, which mean meconium. Meconium can be the fecal matter itself. Lanugo hair, very soft hair on the head of the child. And others such as the squamous epithelium, all can lead to obstruction. Also, you find that it is not just mechanical obstruction, but processes such as disseminated intravascular coagulation and FDP, fibrin degradation products, which can lead to damage and death. Please remember DIC. And this is what has been removed from the lung of the mother. So I find that there are strands over here. This is all squamous epithelium that has got lodged in a blood vessel. So what are all the contents? Squames or aggregation of epithelial cells, meconium, lanugo hair, fat. Sometimes these can lead to mechanical obstruction, otherwise they will cause thrombosis, disseminated intravascular coagulation, and chemical mediators also can be released. Sometimes there can be what is called as a diffuse alveolar damage or ARDS, adult respiratory distress syndrome. What are the other types of emboli? These include, see what I'm seeing in this picture, there are multiple needle-shaped empty crystals. They are the cholesterol crystals. They can occur in a thrombus or in any collection. They are cholesterol crystals, foreign bodies. Suture material. You find that the suture that is used for surgery can enter the vein, it can be carried. Sometimes, very rarely, you find bullets can be carried in the blood away from the site of entry. Cholesterol crystals, vegetations of the heart, particularly in the case of infective endocarditis. All these can be carried. So when it comes to embolism, please do not just answer thromboembolism. There are so many other types of embolism, and each one can be asked as a question. Amniotic fluid embolism is a question. Caissons disease is a question. Fat embolism is a question. And pulmonary embolism is also a question. Gracias.